Good morning. Welcome to the teleconference session of PGDMCH program. Today we will have teleconference regarding MME 103, that is pediatrics component of the PGDMCH program. Today we have three experts. To my right, Dr. Harish Chalani. He is senior consultant of pediatrics at Safdarjung Hospital. He is involved in our program as a counselor and has been also involved as a course writer and editor. He is also a national consultant for IMCI training. To his right, Dr. M.S. Prasad. He is head of the department pediatrics at Safdarjung Hospital. He is also our program in charge and counselor, and also has been involved in the PGDMC's program as a course writer, editor, and also a national facilitator in the IMCI program. To his right, Professor Jagdish Prasad. He is professor at the Ladhiyani Medical College, also involved as a counselor and course writer. He is also a IMCI facilitator at the national level. To his right, we have a student who is representing all of you, Dr. Vidya Kumari. He will be making a case presentation today, and there will be discussion on the case presentation. You all can participate and ask the questions. Before I proceed further, I want to make an announcement that you must have already known that theory, term and form this time is different. Don't xerox from the program guide. You contact your program in charge or regional center, so that there is a separate theory form which you have to fill up, and you have to also attach 50 rupees draft, and you have to send it to the headquarters as the procedure is before. You have to also fill up the new form for practical government examination this year. This will be deposited to your program in charge. Your program in charge will guide you after you complete all your SDC activities and spell activities. But for theory form, you have to start filling right now. So by the end of September, you have to fill it up. I feel you might have submitted your assignments. This year there is only one assignment for every course. So you have total 3 assignments. You have to submit all your assignments by the end of September 30th. Please note it, otherwise you will not be allowed to take your examination in the theory for the December examination. Now in this session we will have a case discussion related to non-IMCI case. We had made 2 case discussions last time, which was related to young infant and older child, which is in the IMCI format. But today we will have 2 case presentations in non-IMCI format and also 1 case presentation in the IMCI format. The first session will be from 11 AM to 11:45, then there will be 15 minutes break. Second session will be 12 to 12:45, and the third session will be from 1 to 1:45 PM. In the first session, I will request Dr. Vidya Kumari to make the case presentation, and I will request Dr. Prasad to moderate the case. Dr. Jagdish and Dr. Harish Chalani will also help in the discussion. Dr. Vidya Kumari.
Good morning to our panel of experts and my colleagues. Today I am presenting a case of a child, Adnan. Adnan, who is a 7-year-old male child, son of Shamshul. They are the resident of Eta and UP. The informant of this case is the mother of the child. Mother complains that the child is having fever for last 2 months, generalized convulsions 10 days back. Child was not able to speak and not able to stand and walk for last 10 days. History of present illness is that the child was apparently alright 2 months back. Then he developed fever. Fever on measurement, the temperature was approximately 100 to 101 degree Fahrenheit, and it was responding to antipyretic treatment. The fever was associated with headache. The child was brought to the local doctors who treated him, but then it didn't improve. So the mother brought the child to Safdarjung Hospital 15 days back for the treatment of fever. During the hospital stay of the child, he developed generalized convulsions 10 days back. The convulsion was associated with frothing from the mouth. The child also passed urine at that time. To control the convulsions, the child was given some injections. Then he slept. When he got up after 4 to 5 hours, the mother noticed that the baby is not able to speak and he was not able to stand also. Gradually he started speaking after 2 days, although it was not very clear. But there was no improvement in the weakness of his right limbs, right upper as well as both lower limbs also. There was no history of head injury or ear discharge, vomiting. There was no history of seizure disorder in the family. There is no history of tuberculosis contact also. However, on repeated inquiry from the family members, it was found out that the child's father had chronic cough 3 years back, but it was not diagnosed as a case of TB. In the past history, there is no history of tuberculosis or diabetes mellitus. The child had never been hospitalized before. Birth history of the child is normal vaginal delivery at home. He is the second child of 3 siblings. He cried immediately after birth. Antenatal period was uneventful. Mother of the child received iron, folic acid, calcium. She also took 2 doses of injection tetanus. His milestones were normal. The baby received complete immunization, including BCG at birth, 3 doses of DPT and OPV. Then he received booster doses also for DPT and OPV, and at 1.5 years, and DT OPV at 5 years. He also received pulse polio drops whenever it was organized in his locality. Dietetic history: according to his age and weight, he requires approximately 1800 kilocalories, but he receives 1400 kilocalories, and protein of 15 gram against 20 to 22 grams of expected intake. The family belongs to a low socio-economic group. On examination, the child was conscious, cooperative. He was well oriented in time, space and person. His vitals are pulse rate 110 per minute, radial pulse which was bilaterally equal. There was no radiofemoral delay and it was of good volume. His blood pressure 106 by 70 millimeters mercury. On the day of examination he was afebrile and his respiratory rate was 26 per minute. Anthropometry: his weight is 15 kg, height is 113 centimeter as against expected of 116 centimeter. On general physical examination, mild pallor is present. There is no icterus, no cyanosis, no pedal edema or facial puffiness is there. Ear examination, no abnormality was detected. There was no lymphadenopathy, either cervical or axillary or inguinal. Lymph nodes were not found. On systemic examination, examination of the central nervous system, His higher functions are normal. There is no neck rigidity. No signs of meningeal irritation were present. Seventh cranial nerve was involved. Upper motor neuron type of palsy on the right side. There is no involvement of other cranial nerves. On examination of upper and lower limbs, on right side the tone is reduced, both upper and lower limbs, and there is no power, grade 0 power is there in both right upper and lower limb. However, on left side the tone is normal and power is also normal. Examination of the reflexes, plantar reflex, it was upgoing on right side and downgoing on the left. Ankle jerk, knee jerk, triceps, biceps and supinator, all reflexes were normal. He responds to painful stimuli. Other systemic examination, chest, there is no adventitious sound, bilateral air entry was equal and breath sounds were vesicular in nature. Per abdomen it is soft, no organomegaly was there. Cardiovascular, both heart sounds S1 and S2 were heard and they were normal. Murmur was not there. There was no gallop or any other adventitious sound. Now I will be telling the summary of this case. 7-year-old male child who is fully immunized, came with history of fever for last 2 months, generalized convulsions 10 days back, followed by inability to speak and unable to walk and stand due to weakness of right side of his body for last 10 days, with previous normal birth history and normal milestones. Who on examination found to have grade 2 malnutrition along with right hemiplegia of upper motor neuron type with right 7th cranial nerve palsy, upper motor neuron type, without sign of any meningeal irritation. Provisional diagnosis of the case: it can be intracranial tuberculosis with lesion of cortex with grade 2 malnutrition. DD could be partially treated.
Okay, so Dr. Vidya has presented a case which has got chronic history of presentation, prolonged fever is there is history of headache. The child has got hemiplegia of upper motor neuron type, including the cranial nerve palsy, that is 7th nerve palsy, as well as child is malnourished. But right now there is no signs of meningeal irritation. Vidya, can you tell me what are the signs of meningeal irritation?
So signs of meningeal irritation, there can be neck rigidity. Kernig sign will be positive in that when we put our one hand on the back of the head of the child at the region of occiput, and while the child is in lying down position and try to flex the head of the child, then chin touches the chest. But if there is meningeal irritation, then neck becomes stiff and it does not touch the chest.
So neck rigidity is the most important sign of the meningeal irritation.
Yes.
So with all that, what is your provisional diagnosis? And have you missed any thing to examine? Though it may not give any information, but still examination should be complete, and I believe the examination of the throat, head, neck and spine appearance should be done anyway.
Yes.
Now what is your working or provisional diagnosis right now?
The provisional diagnosis is intracranial tuberculosis with lesion of the cortex along with grade 2 malnutrition.
And can you please tell me the grounds on which you are suspecting tuberculosis?
Tuberculosis because there is prolonged history of approximately 2.5 months. Then he is having less weight as compared to his age, and positive contact history is also there, although that is not clearly diagnosed, but chronic cough history that is present. His father was having chronic cough.
Well, in such situation you could have asked some more questions. Whether the chronic cough was associated with daily rise of fever, evening rise of the fever, whether the chronic cough was associated with expectoration. Those things should have been, whether the chronic cough was associated with any time hemoptysis, blood mix sputum. So those things could have confirmed the diagnosis. Anyway, now what is your differential diagnosis in this case?
Differential diagnosis, it can be partially treated pyogenic meningitis, and second can be encephalitis. Third, because of convulsion we may put epilepsy, but that may not explain in this case because Todd's palsy is there in epilepsy, but that improves maximum within 7 days, usually within 48 hours. But
is that associated with fever?
No sir, epilepsy case is not associated with fever.
Okay, so fever is going strongly in favor of tuberculosis rather than epilepsy.
Yes, sir.
So to prove your diagnosis and to rule out other possibilities, what investigations do you plan right now?
So right now there are some special investigations and some general investigations. Special investigations regarding this case are, first we will do fundus examination.
Right.
If there is no papillary edema, then we will go right ahead with lumbar puncture and we will examine the CSF. And third will be CT scan of the head. And general investigations will be hemogram, TLC, DLC, Mantoux test, X-ray chest, and LFT and RFT, etc.
What is it? RFT?
Renal function test. Blood urea, serum creatinine, sodium, potassium.
Anyway, that may not help right now in diagnosis.
Yes.
But what is expected of Mantoux test?
Mantoux test, sir, expected maybe it is because the child received BCG at birth also. So it may be positive. But even if negative.
What do you expect in the?
What do you expect in this particular case?
Or do you feel this, suppose this is negative, it rules out tuberculosis?
No sir, even if tuberculin test comes out negative, it does not rule out tuberculosis.
So Mantoux basically is a test which supports your diagnosis if it is positive,
Yes,
right?
sir. Yes, sir.
But if it is negative, then it does not rule out, because in case of the fulminant tuberculosis, or if it is malnutrition, grade 3 or grade 4 malnutrition, then this test may be negative.
Okay.
So Mantoux, yes, if it is positive, it supports your diagnosis. And apart from this, maybe in the discussion, like you said that you have got right-sided upper motor neuron lesions, but you had the tone and the power which was 0.
Yes.
So how do you support that this is an upper motor neuron lesion? On what basis you said it is upper motor neuron lesion?
So usually in upper motor neuron type of lesion, there is spasticity, tone
Right.
is increased.
Okay.
That's right.
Is that
But
right?
in this case, the tone is reduced.
Okay.
So
So how did you say that this is an upper motor neuron lesion? I agree with you. Still, I agree that this is an upper motor neuron lesion. But
because there is involvement of speech also, and when the cortex is involved, then it is upper motor neuron.
any
type.
other clinical signs which can point towards in favor of an upper motor neuron lesion?
Seventh cranial nerve is also involved.
In some reflexes, which you
Some
can-
reflexes, or plantar reflex is upgoing, that is strongly in favor of upper motor neuron type.
right.
That's right.
Yes.
So sometimes you may have tone decreased,
Yes,
but the
sir.
plantars, if it is upgoing, that goes in favor of a
Yes,
upper
sir.
motor neuron
Upper
lesion.
motor.
Even the other side, let's put it when the tone may be increased, the plantars may be downgoing also.
Yes.
Still it can be the upper motor neuron,
Okay.
because you can explain it on the basis of an increased plantar muscle reflex, that is known as the Morrison's reflex.
Morrison.
By that you can again say that this is an upper motor neuron lesions, right?
Right.
So that is one. And one important thing which Dr. Prasad also highlighted, that throat examination, and you must also palpate the carotids, because in this child you found there was an acute, there was a history of fever, prolonged fever, and there was an sudden involvement of the paresis or paralysis of the one
Right.
side of the body.
Yes, sir.
So one must rule out the vascular causes also in this. So examination of the carotids is also mandatory in such cases.
Right, sir.
Dr. Jagdish Chandra, if you would like to then.
Yeah, I think she presented the case quite well, but still there are certain things I think we should include. When you described that the child had convulsions,
Right, sir.
it's very important to tell whether it was associated with any loss of consciousness or not. If there was, since we are talking of a child who has got probably an intracranial infection,
Right,
it would
sir.
be important to know whether the child has any loss of consciousness, and if it was there, then how quickly he recovered from that. Because right now on examination you said that the child is conscious, cooperative,
Yes.
and is alert, and his heart functions are normal. So that's an important aspect in the neurological case.
Yes.
The other things as highlighted, the description of tone, etc.
Yes, sir.
The seventh cranial nerve you said is upper motor neuron type lesion.
Right,
How, why do you say that it is upper motor neuron and not lower motor neuron?
Sir,
Can
on
you explain that?
yes, sir. On examination of the face, the forehead was not involved. I mean, forehead muscles were contracting
Okay.
because they
What about the eye closure? Is it?
eye closure was there.
Okay.
Yes, sir.
So you mean that it's not the full face, half of the face is not involved.
Yes, sir.
Is it the upper part is spared and lower part involved? Is it like that?
Yes, sir.
Okay. So what sign you got that
Sir,
tells you there is
sir,
seventh nerve involvement?
retraction of the angle of mouth.
Right.
Yes.
So only lower half is involved, which
Yes, sir.
suggests that this is upper motor neuron involvement.
Right.
And mostly when we have patients with hemiplegia, the upper motor neuron lesion tends to be on the same side as that of hemiplegia,
Yes,
which
sir.
is there in
Which
this
is
case.
there,
Right.
sir.
So, and just one small point, you described that the child's height is 100 centimeters. You must have taken the length. No, the child is not able to stand. Just be careful. This is a very small point. but-
Yes, very
because the child was not able to stand, you must have
Yes,
taken the
sir.
length.
Length, yes.
So describe that as
I
the length.
should
Right.
write
Yeah,
length,
you could
okay.
describe it as length.
Right, sir.
Yeah, but another thing now, what is the site of lesion anatomically? Let us put it. You said it's right hemiparesis.
Right.
You said it is aphasia is also there, and can you pinpoint what is the site of lesion? Then we can come to the etiology later. Do you think it is a cortical lesion? Do you think it's an internal capsule lesion, or lesion of the pons?
Sir, it can be lesion of the cortex.
Okay.
And-
What are the points in favor?
Points that are going in favor of that is that there is hemiplegia plus speech is involved.
Okay.
Although for cortical lesion, monoplegia would have been better in favor of that. But hemiplegia is also there, maybe a large section of that cortex is involved.
Yes.
Plus aphasia is there, so that goes strongly in favor.
Any other point which you had mentioned also in history?
Seventh cranial nerve.
No, history of convulsion.
History of convulsion,
So
right.
history of convulsion, aphasia,
Yes.
and then hemiplegia, they are all go in favor of a
Cortical
this.
lesion.
Can it be pons? Now let us put it. Can it be, if suppose someone asks you, can this lesion be at the level of the pons?
If the lesion is at the level of pons, then sixth nerve also will be involved.
Okay, very good.
So which is not in this case.
Any other point against the...
Plus speech will be spared if the lesion is at the level of pons. But here speech is involved. So
Any other...
convulsion will not be there.
Convulsion may or may not be there.
What will be the type of seventh nerve involvement
Yes.
in pontine disease?
Yeah, that will be lower motor neuron.
Lower motor neuron type, and on the same side or the other side?
Other side,
Right.
sir.
So it will be
Opposite
on
side.
the other side of the
So,
hemiplegia.
so friends, please remember that whenever there is a lesion on the level of the pons, it will be a contralateral hemiplegia.
Right.
So, it and the facial nerve will be lower motor
Lower
neuron,
motor neuron.
right? Now, as we were discussing, you said the investigation, since you are now putting the choice on intracranial tuberculosis without meninges involvement, and you said lumbar puncture
Yes,
should be
sir.
done. Can you tell what are the features of in favor of tuberculosis? What do you expect in lumbar
On
puncture?
CSF examination.
Okay. On CSF examination, if it is tuberculous type, then the CSF will be clear, or there can be cobweb type of appearance.
Okay.
Second thing is that protein will be above 40 and sugar less than 50. That is that will be both in
That will be
pyogenic
pyogenic
factor.
also,
Yeah, that
but
will be there
anything
also.
which can,
Chloride
protein
will
is raised in much more in which condition? Tubercular or pyogenic?
protein tuberculous.
Okay.
Plus chloride will be very less than 600.
Mhm.
That goes strongly in favor of tuberculous type of lesion.
Okay.
And on staining as well as culture, acid fast bacilli can be detected if it is tuberculous type of lesion.
How do you stain that? AFB?
Gill-Nielsen stain.
Okay. Do you remember the technique of staining? Friends, it
very
is
long.
important actually. Sometimes you are asked actually in the, and many of these things you are doing in the side lab also. So be ready with that question also from the examiner, how to stain Gill-Nielsen, and look for that. Right? Okay. So that's how you differentiate any other test
Plus,
which you can latest
one more
technology.
important point which I missed.
Mhm.
In tuberculous, lymphocytes will be predominant.
Cellular response you don't
Cellular
Cellular response will be lymphocytes, whereas polys will be there in
In
pyogenic
pyogenic,
meningitis.
yes.
Any recent technique which can
CT scan
no, in the CSF
in the CSF,
we can do PCR,
PCR, right?
right? So we can do that testing also. And what do you expect in the CT? You said CT scan will be done. What do you expect in this particular case?
Suppose if there is tuberculoma or any
Okay.
this thing, then it can be because it is space occupying,
Mhm.
so it can be detected in CT.
But tuberculoma will not give such a large extensive lesion. So
Yes, sir.
how will you explain? So what additional thing which you can get in the CT?
Vasculitis,
The
that can be
vasculitis, so
vasculitis.
maybe the infarct you may be getting, right?
Right.
Or
Exudate.
basal exudate might you get.
Yes.
So,
Mm.
so basal exudate in the vasculitis in the form of the infarct, and then you might get tuberculomas. So
Yes,
they
sir.
will be the features. Okay, let us put it this as a, so how will you treat this child?
Sir, initially, because there is some overlapping, whether it is tubercular or pyogenic, so we will start both with antibiotic as well as ATT treatment.
No, but now you have done the lumbar puncture. So now,
So, yeah, now
That was only
ATT,
provision.
If the diagnosis is intracranial tuberculosis,
Yes,
let us
sir.
say, then how
Yes.
will you manage this child?
we'll start ATT right away, and we'll give INH isoniazide 16 to 20 milligram per kg of body weight, then rifampicin 10 to 12 milligram per kg of body weight, ethambutol 20 milligram per kg body weight, and we can give streptomycin injection also 20 to 40 milligram per kg body weight. And it
So
will
you
be
would
very
like to start 4 drugs, as
yes,
you
sir.
said,
Yes, sir.
INH, rifampicin, streptomycin and ethambutol.
Yes, sir.
Any other choice which we can, better choice which we can use?
There is one essential preparation missing. That should
That
be
is what
included in
Dr.
the,
Prasad is
Pyrazinamide.
trying to get from you.
from the first 2 months we include that component.
Pyrazinamide?
Yeah,
Pyrazinamide.
pyrazinamide. So
Which
what
hits the intracellular
Yes, sir.
environment.
dose of the pyrazinamide? 30 to 35
30 to
milligram per
35
kg per day. Okay.
Yes.
What else? That is the ATT. You have now described 5 drugs. And how long you are going to give all the 5 drugs?
Intensive treatment initially for 2 to 2.5 months, and then we'll taper off and we'll continue with isoniazide and
Taper off, what is the correct word?
No, sir. We'll stop other drug and we'll continue with isoniazide and rifampicin.
What will be the total duration of the treatment?
Total duration it can be from 18 to 24 months. That is up to 2 years.
It is slightly...
Yeah, slightly. You know, nowadays with the intensive regime of 4 drugs, that is INH, rifampicin, pyrazinamide and ethambutol, we avoid streptomycin because of the toxicity. So 4 drugs are given, and as Dr. Prasad was mentioning, 2 months.
Right.
These are the drugs, and then you stop pyrazinamide and ethambutol, and you can continue with INH, rifampicin for next 10 months. So total duration has been now curtailed to 12 months. And the dose also, Vidya, you mentioned higher. INH you give 5 milligram per kg,
5 milligram.
and rifampicin in a dose of 10 milligram per kg. So these are the doses which, of course, the pyrazinamide in this little higher dose is given. Apart from this antitubercular therapy, any other thing which you would like to give?
We would like to give vitamins and nutrition because he is having malnutrition. So according to his calorie requirement and protein requirement, we'll give him additional food, supplement we'll be giving him.
Energy dense nutrition.
Protein nutrition.
Okay.
So we should not forget the supportive care also along with it, and since there was a history of convulsion, so we would like also to take care of the convulsion part also with the anticonvulsant drugs, right?
Yes, sir.
And would you like to give steroids in this child? Or what is the indication of giving these steroids?
Steroids, yes, we can give steroids for early recovery.
Which are the cases where we would like to consider? See, if it is a tubercular meningitis, when the cell count is very high and there is a component of the meningitis,
yes, sir.
that is a strong indication goes in favor of the use of the steroids, right?
Right, sir.
Okay. Now,
I think in management we have to supplement something more. She has described antitubercular drugs. She has described supportive management with nutrition, with high energy dense. But then the important thing is that this child has got hemiplegia. For that, this child also requires physical medicine therapy. So
Yes,
physiotherapy is required. So that is an important thing.
Yes,
I think.
Okay, I think we have already taken care of the first case. In the examination you may get a long case from the nervous system, or you may get from hematology or other areas. So as an example, we have discussed this as a long case for the nervous system. Our next case will discuss related to hematology. Just to summarize what has been done, that whenever you get a nervous system case, try to pinpoint the level of lesion, and you have to justify that, because level of lesion is very important, and you have to correlate with your findings. And as for the management, if it is infectious, then it can be managed. If it is due to something else, maybe some intracranial lesion, then maybe the surgical side, or if it is like tuberculoma, it may be treated with anti-tubercular treatments. So that management part is different, but what in your exam we want you to focus, that you have to correctly make the assessment and the level of lesion for that case. Dr. Chalani, will you like to give some hints about this case?
Yeah, I think the case was discussed and she had presented very well. The only thing is that whenever such cases are there, CNS cases, though most of the students feel that it is a difficult case, but if you are taking a good history, systematic history you are taking, believe me, you can reach the diagnosis in a CNS case by a good history and examination. You can even define the level of the lesion, anatomical level of lesions, and do not miss any sign. Whatever the signs which you are getting there, try to put them together, and with the good history, I would say that good history and examination can reach to the diagnosis in most of the cases in CNS.
Okay, yeah. I think now we will go for the second case. I will request Dr. Chetan Grover, who has joined us now. She will be making the presentation. Please note, we will continue the session. So there will be a break at 11:45, but we will continue wherever we will leave it after 12 o'clock. So Dr. Chetan, you can start presenting the case. Dr. Chetan, please.
Good morning to today's panel of experts and my dear colleagues. Today I am presenting the case of Simran, who is a 10-year-old female child. She is the daughter of Mr. Nizam from Muradabad, and she was admitted to Safdarjung Hospital 9 days back. The chief complaints of the child, as told by the father and the mother, were fever which started 10 days back, and second complaint of rash and black spots all over the body for the last 7 days. There was bleeding from the gums since the last 3 days. The child was apparently well 10 days back when she developed fever. Fever was of moderate grade, continuous, accompanied by chills, and relieved after taking some medicine after 2 days. This was followed by the appearance of rashes and black spots all over the body. The rash and the black spots first appeared on the thighs and later spread to all over the body in the next 2 days. In the beginning, the rashes were a little reddish in color, but they changed over a period of 3 to 4 days to a little darker and blackish color. However, there is no history of passage of blood in the stools or urine. There is no history of any hematemesis. There is no history of bleeding from the nose or ear discharge. There is no history of joint pains or body aches. There is no history of seizures and convulsions. And apart from the medication that she took for fever, there is no history of any other drug intake or exposure to radiations. In the past, there is no history, similar history of a similar illness in the past. There is no history of any hospitalization or prolonged medication. In the family, there is no history of similar illness in the family. In the birth history, the child is the fourth in birth order out of 7 siblings. She was born of a non-consanguineous marriage by a full-term, normal, home-conducted vaginal delivery. As told by the parents, all milestones were acquired at the requisite age. Child is fully immunized up to 5 years of age. In the dietetic history, she is taking a diet of about 1500 to 1600 kilocalories per day, along with a protein intake of 20 to 22 gram per day. The child belongs to a low socio-economic group. Her father is an auto rickshaw driver and earning about 4,000 rupees per month, which is divided among 9 family members. In general physical examination, she is conscious, cooperative, moderately built. The child is afebrile and having severe pallor. There is no jaundice, no edema feet, no cyanosis. Hydration is adequate. Pulse 90 beats per minute, regular and good volume. Blood pressure is 110 by 70 millimeters of mercury. In the anthropometric measurements, weight is 25 kgs, height 131 centimeter. This was followed by general physical examination. On examination, I found that there were bluish and blackish petechial spots and purpuric rash all over the body. The lesions were non-blanchable and varied in size from 1 to 5 millimeter. There was a hematoma which was measuring 2.5 centimeter between the second and third web space on the left hand. This hematoma was erythematous, fluctuant and tender. There was bruising on the left eyelid which was bluish blackish in color. The buccal mucosa, gums and conjunctiva were normal. The cervical and axillary lymph nodes on examination were not found to be palpable. There were 1 or 2 small inguinal lymph nodes on the right side which were measuring less than 1 centimeter in size.
What, do you think that these inguinal lymph nodes are clinically significant?
Any lymph node which is more than 2 centimeter in size could be significant, but since they are very small in size, they are not significant. But as a routine, we examine all the lymph nodes.
Yeah, so inguinal lymph nodes are taken as significant if they are 2 centimeter
or more in size. There are no other visible bleeding sites from the body. On systemic examination, I found that the abdomen was soft, non-tender, liver and spleen were not palpable, and there were no other masses palpable. In the cardiovascular examination, heart sounds S1, S2 were normal, no added sounds or murmurs were heard. On examination of the respiratory system, air entry was found to be equal and normal on both sides. There were no adventitious sounds. On the examination of the central nervous system, I found higher functions were normal. There were no cranial nerve palsies. There was no focal neurological deficit. Reflexes were normal. Power and tone of both upper and lower limbs were normal.
So I think we can stop here, and we will start the next section with the summary of your case so that we have an easy recapitulation, and then we will discuss the differential diagnosis.
I think before we just break, I want to just again tell the students, please note, this time the theory term and form is different. Please contact your regional center or the program in charge and fill up the theory term and form in time so that you don't miss the examination in December 2007 this time, because you have to deposit also ₹50 per course. So if you are taking all the 3 courses, then you have to give ₹150. Similarly for practical, it will be a separate form and it will be filled up separately in the month of November. But for theory, you have to fill up the forms right now. So now we have a break for 15 minutes. We will meet again at 12 o'clock. Please be with us.